Hello, welcome back to the NCCDP YouTube channel. I am your host, Alexandria, and today we are going to be talking about pain management in dementia with the lovely Kari Johnson.
Hello.
Welcome back.
Thank
again.
you.
And for anyone that hasn't seen our previous videos with you, do you mind just sharing a little bit about who you are and what you do?
Yes. As we've talked about before, that's always such a loaded question because
Yeah.
I'm kind of doing lots of different
She
things.
does everything.
Yeah. Well, sometimes I think I'm doing sort of good at a lot of things rather than really good at a few things. You know what
Yeah.
I mean? I'm an occupational therapist, board certified patient advocate, educator, and I also teach for the NCCDP corporate and my own private sessions as well.
I'm really excited about this topic specifically because, as I mentioned to you, I didn't realize what pain is associated and involved with dementia. It was never something I thought about and never something I realized. And I even asked you a few days ago. I was like, wait, what? So, do people with dementia have pain?
Absolutely. Absolutely. You know, when you think of just getting older, joints getting older, I mean, even now, I'm only in my mid-40s, but I get up in the morning and I'm like, whew, this got a kink here and a kink there. Nobody told me this started in your 40s. I thought it was like I had a few more years. If you think of, you know, someone that has dementia isn't able to move as freely as they once could, may have arthritis, but can't tell someone. So then they're just sitting there with the pain with no relief. I always say to people, arthritis doesn't go away when the dementia has developed. If they had arthritis 10 years ago, it's just getting worse. So that pain is getting worse. You know, there's several factors involved as to why they have pain. You know, it's a complex area. And I think because a lot of them can't say they are in pain, you know, we don't realize it. We don't think about it.
Are they able to tell us if they're in pain? I know you kind of mentioned that they're not fully able to tell, or what's the kind of the situation with that? How can they communicate that?
Typically, they're speaking to us with behavior. One of the types of pain, or one of the causes of pain for those that have frontal lobe damage or impact from dementia is something called peritonia. Gegenhalten is the German word that it's based after, which I'm hoping I said right. I call it peritonia. There's a couple different types. Oppositional peritonia is the one that you see the most. What that is that the muscles are firing when they shouldn't, because the part of the brain or areas of the brain that control motor planning, motor control, they have been impaired. And so that is because of the dementia. Your original question was?
How are people with dementia able to communicate that they're in pain? Or how do we know that they're in pain?
In that particular case, with the peritonia, when they're having that, they're typically not as verbal. Mm-hmm. So how you'll observe it is that they're pulling back. Someone might be assisting them to get dressed and the arm is pulling back. They're not doing that on purpose. That muscle is misfiring. And so then they may be labeled as being difficult or they're combative, when in fact it's something, you know, if you didn't move, you know, a young person in the hospital that hasn't moved for 12 hours is going to be stiff, let alone someone that's much, much older, may have a history of arthritis, also has peritonia. So then you have contractures that can form, you know, where those muscles have shortened and then they can no longer. Mm-hmm. For those that are in the late stages of Alzheimer's disease, everybody for the most part is going to have tight ankles, tight knees, tight pelvis, tight shoulders. And that's painful, especially when someone is passively trying to move it. So you're trying to move their arm and that muscle tone kicks in. Imagine having like a muscle spasm and somebody pulling on it. It doesn't feel good.
Would you say that the pain that people with dementia feel, is it more so associated with other things that are also going on with their body? Or
Absolutely.
Okay.
Absolutely. You know, I've said this in one of our other chats. You know, sensory processing is a big issue. Mm-hmm. It's kind of the core of what dementia is, the ability to take in information externally, the external environment, and the internal environment. So something such as constipation or pressure on your bottom or a cut on the leg, the brain may not be able to interpret that correctly. And even if it can, then not have the ability to form a plan and carry that plan out. So it's really perceptual. It's, in that case, again, we have to try and assess and figure out where is this coming from.
It's kind of crazy too, because I was like how I mentioned earlier that I never even considered about pain associated with dementia. I also, because of just like not thinking about it, it never occurred to me that someone with dementia could also have other like health concerns going on. Because in my mind, I'm like, well, dementia seems like the main health concern. Like, what else is there to think about? But really, there could be arthritis. There could be
Absolutely.
so many other things going on with like physically, mentally, emotionally that like
Absolutely.
I wouldn't have thought about.
Yeah, I mean, in my career, I mean, I've been in healthcare over 25 years, and the medical histories for people are just growing and growing and growing. And you read it, and then you go to meet the patient, and you're expecting that this person isn't going to be moving, and there's somebody up that's folding clothes or, you know, walking
Yeah.
around the room, etc. But comorbidities is a good point, meaning other conditions. An example would be my father having a hemorrhagic stroke, and it affected his left side, his sensory system. So water would feel like needles to him. And so when I would go to visit, I'd say, hey, Dad, how long has it been since you had a shower? And he's like, you really want to know? I'm like, no, probably not. He's like, but I don't smell. Clothes hurt, so he oftentimes was naked. So his thought was, because he's naked all the time, he's getting aired out. Everything's airing out. So that's why he doesn't smell. So when we had to move him to the nursing home, I dropped him off feeling terrible. I came back the next day, and 24 hours later, I walk in, and this man has had a haircut, a shave, a shower, and is looking like $1 million. And I said, what happened? He said, well, they gave me a Hollywood perm. I have no idea what, I still don't know what a Hollywood perm was to him. I said, well, that's awesome. They gave you the spa treatment. I didn't realize that they were still using whirlpool baths at that particular place. Those are something that when I started as a CNA were real common. It has a chair and it lifts you up and lowers you in this tub, and it's this like nice whirlpool bath. They're not common at all anymore, but they had that there, and that wasn't painful for him. Plus, he said that the woman that assisted him wasn't bad to look at. My father was always after a date, so no matter what their age was. Not older, though.
Not older?
Nope, no, never. No. First year he was there, he was voted the Valentine's King. But the Queen, he said, was a little bit too old for him. I know. Yeah. He was a
Not
character.
into the older women.
But yeah, those comorbidities are a huge factor. Neuropathy, can come with dementia alone. Diabetes, just aging. Thin skin is a huge factor as well. For those with dementia, oftentimes there's weight loss. And so heavy water pressure is going to feel much different when you don't have kind of as much cushion as you once did.
So once you know that this person has pain, what do you do?
Well, I specifically, as an OT, would utilize aquatic therapy, not just for the pain relief. And when I say aquatic therapy, a therapeutic pool is 92 degrees or above. Otherwise, typically people just have more pain. That's one of the methods that I would use, but I'd use it for balance, I'd use it for pain, I'd use it for, several different aspects. And it's not about the swimming, but I was also able to assess their spine, their pelvis, and try and figure out whether a different seating system was necessary, because they might have a contracture. In those later stages, people can get different types of contractures where potentially the pelvis is not even anymore. They're tight on one side. And so imagine if you're trying to sit all day long on one of your bottom cheeks. That's not comfortable. And then people wonder why are they not eating? Well, they're not comfortable. So aquatics was a big one for me, being able to kind of look at that whole picture. Also, I would utilize kinesiotape if needed, if there was swelling, if there was pain. Other modalities that are out there that therapists are typically aware of, ultrasound, those types of things. But manual therapy, trying to just loosen the muscle with your hands. And then there's also utilizing palliative care. Typically they're underutilized because people don't quite understand the difference between palliative and hospice. But, bringing in the team, let's the whole team look at this. Nutritionist is looking at intake or looking at diet. so that they don't have a bony bottom that's hurting as much. The physical therapist is looking at, the lower extremities, do we need to be having a stretching program? Nursing is looking at what sort of medications can help. OTs are looking at what adaptations can I make maybe to the clothing so that it doesn't hurt to put on, something that, the shirts are different so that they don't have to raise their hands over their head. Well, I would say number one, utilize the team. I talk about that over and over in seminars. I think people think I'm a little obsessed, but you would think, I'm sure a person that's not in healthcare thinks that those that are in healthcare under one building, that they all know what each other does or what they're trained in.
They don't.
No, no, not at all. No idea. A lot of times they'll say OTs, you give baths. Yeah, you give baths. Or they'll call us the shower lady. Yeah, shower lady with a master's degree. That's okay.
Yeah.
It's fine.
Takes a master's degree to know how to shower.
It does. I mean, in certain senses of how I need to do it. You know, those within the building in a building or even in the community, home health, whatever, don't necessarily know, oh, an OT does aquatics, an OT does this, and I've had the benefit of working with other therapists and with facilities that were very outside the box or, let's really push to be innovative. So that's had a huge impact on my career.
When referring to like the team, who are all of what are those roles that kind of go together in this team?
So it depends on which environment we're talking about. If we're talking about, a skilled nursing environment or assisted living, you've got physical therapists that are going to be looking at gait, balance, transfers, a lot of times lower extremities, but that's not always the case. A lot of PTs will look at upper extremities as well. They're looking at movement for the most part, how someone's getting from one place to another place, standing safely, range of motion. Then there's occupational therapists, and our areas really focus on those activities of daily living, dressing, bathing, grooming, toileting, showering, and then potentially instrumental activities of daily living, money management, shopping, medication management. The way that, but we don't just do those things with someone. I may recognize that this person has got weakened hand muscles. So I need to work on strengthening hand muscles or work on coordination so that they can manipulate money or their toothbrush or their fork. If they have arthritis and they're not able to strengthen, if that actually is contraindicated or not good to do, then looking at adaptive equipment, a built-up handle. There's these forks and spoons out there that no matter which way you turn them, they won't spill. They level out.
Oh, that's cool.
There's tons of different equipment. In terms of speech therapy, they're going to be looking at cognition, speech. A lot of people don't know that they have a specialty in cognition. OTs do as well, but not oftentimes to the extent of what a speech therapist does. But it also depends on the therapist's interests and what they have decided to focus on. And speech therapists in this type of setting, a lot of times looking at swallowing, making sure that it's safe to swallow. If it's not safe to swallow, looking at, is that an acceptable risk? Because we want that person to be able to joyfully eat what they want to. So that's the therapy portion. Nursing, their role is to kind of, keep an eye on everything. Intake, toileting, medications, kind of making sure that all that's balanced out. If there's pain, making referrals, letting the doctor know. Any of the team members can let the doctor know or the nurse practitioner know. But for nursing, really kind of monitoring those things that would help the person maintain homeostasis. Intake, output, that's a big deal. The physicians, obviously, prescribing medications, trying to help with diagnosis. And that's also all the other disciplines as well. What are you seeing behaviorally? What are you seeing functionally? What factors do you think could be at play here that somebody else may not have seen? Dietitian, and they may be looking at what supplements can we add so that this person does have more meat on their bones so that they aren't having pain. With speech therapy and communication, I'm going to jump back to that. For someone that can't express pain, they may look at a chart or something, a communication board, some way for that person to point to something or spell out something if they're not able to talk, so that they could tell that someone's in pain. And then the other things that we'll get to that in terms of assessment.
You kind of mentioned a little bit about like methods to then understand what their pain's like or what's going on. So are there methods then to understand the nonverbal cues or things like that?
Absolutely. I mean, there's standardized, meaning that it's a certain test that someone did research and formed. And then there's informal, knowing the person and just taking a look like, oh, that person's in pain, they're limping, or they're not lifting their arm up. So there's some that are just about observational skills, but then there's others that assess behavior. It's a pain scale, but you're looking at facial expression, movements. There's several out there. And then there's also anxiety scales or agitation scales. So because someone with dementia, if they have pain, may be agitated, just like someone without dementia may have pain and be agitated. So there's charts for that, looking at how do I score, what am I looking at and what is the score? What is their level of anxiety at? Then making some adaptation, providing some treatment, and rescoring it. So yeah, there's a lot of scales out there.
And I know a common term in dementia care is what, person-centered care. Is that right? How does that apply to this?
Doing what is most beneficial for that person. Also looking back through their history in terms of how did they deal with pain 20 years ago? Because they may not want to take medications. That may not be something that they wanted. Also there's the factor of, we talk about person-focused care. And if we're not looking at the person and their whole life history and how the family's view is and all of that, it's not person-focused, it's just focused. It's just us doing what we want. So I think person-centered with pain, it's going to be different. And you'll see that where so-and-so's having pain. Well, let's give them some Tylenol. So, somebody else is having pain. Well, let's give them some Tylenol. We can't do that. They're all different. We have to dig deeper. We have to center in on who that person is and what their experience is.
I don't think I had any other questions about pain management.
Pain is a big area, and people, what I found not surprising but helpful, I obviously am around people in healthcare all of the time. So working with you, and you said, this is, when you mentioned that certain things are surprising, it again highlights to me how much our society does not know.
Yeah.
And how do we work on improving that or increasing knowledge.
And that's what we're trying to do today.
Yeah. And I think the other factor is, for my father having the pain that he did, central post-stroke pain is a wicked beast to treat. I've had my own clients with it, and it's related to the type of stroke that he had and where the stroke was. And sometimes he'd have a hard time in the emergency room. He said to me one day, he said, I wish that they'd just treat the pain, not judge it. And I said, that's a really good thing to say, Dad. Why do we judge it? Why do we judge someone that's in pain?
Yeah.
We think, well, you're not in that much pain. Because we love in the healthcare industry to say, on a scale of 1 to 10, what is your pain? And people say a 7, an 8. And then the person will say, well,
it's not a 10.
Are you sure? Yeah. Are you
You're
sure?
fine.
I mean, I broke my leg, and that is my 10. So that's what I measure across my life. That was the most pain I ever had. And I think that's for everyone. Everyone's 10 is probably the worst pain that they ever had. Because otherwise, how would you know what it?
Yeah, and then with that, if we're kind of on our own kind of scale with that, just based on our own bodies and histories, how am I to tell you that you're not actually in that much pain? Because I've felt this pain, so you're fine. Like,
yeah,
it's harder. You can't fully understand what someone else is really feeling, and then judging that.
And
pain.
people would sometimes say, "Well, your dad says he's at a 10, but his blood pressure and his heart rate is fine." And I'm like, that's okay. and let's go ahead and treat his pain. He's in pain, okay?
Yeah.
And with the type of pain that he had, narcotics don't touch it because it's it's not related to body structures. It's related to the neurological pathway being broken. So he wasn't asking for morphine or any of that. It was more, gabapentin and some of those drugs that are for nerve pain. Bert would say, treat the pain, don't judge it. And
I
I
love
would
that.
say assess the pain and treat it. We have to assess.
Out of curiosity, I mean, I'll use Bert as a specific example for this question, but it can apply to a lot of different situations. With Burke's, he also had he had the stroke and the different effects of that, and then adding in dementia. I'm trying to think how to word this. Did that the pain that he was feeling from the effects of the stroke, was he aware of what was happening, or was it just pain that he was feeling and he didn't fully understand? Like, how did that affect him and his idea or his understanding of what was
Um,
happening? Does that make sense? I'm
yeah,
not sure of how to
no,
clearly
no,
word
no.
that question.
I think I got it. And if not, I'll just talk anyways.
We'll figure it out. We'll get
Yeah,
there.
yeah. The pain started before the dementia. His stroke was in 2007, and pain really started that year. His perception definitely changed with the dementia, or if he was hospitalized, or his electrolytes were off, or if he was drinking, that would help the pain. With the certain type of pain he has, there is a huge use of substances for people, and a huge suicide rate
Mm-hmm.
because it's such a barrier to treat. What I noticed with the dementia, somebody would give him a pill, and he'd swallow it, and he'd say, "See, it's working already," and he had just swallowed it.
Mm-hmm.
Now, he wouldn't have said that prior to the dementia, because he would know how that person would interpret it. Well, of course, it hasn't started to take effect yet. You literally swallowed it 2 seconds ago. With the dementia, though, he wouldn't think of that, like that social part of it. Well, this person isn't going to
Mm-hmm.
believe me if I say something like that. The caveat there, though, is with a neurological pain like that, someone providing comfort may actually bring the pain level down, because you relax, or
Mm-hmm.
our brain is a miraculous thing. I mean, there's a lot of
Yeah.
people that treat their own pain without drugs. So I would just say that with his pain, it didn't really change. He didn't report it as much as the dementia progressed. When it was, then the drinking would increase. His ability to report it and have someone believe him. There was an instance in an emergency room, and when he was in the hospital, the way that I would kind of know what was going on was by watching his online chart, and it said
Mm-hmm.
behavioral rapid response, and I thought, uh-oh. So I called and I said, "This is Kari Johnson, Bert Johnson's daughter." And the nurse was like, "Is this your dad?" And I can hear him screaming. And I could see that there's security guards posting outside in the notes. And I'm like, oh, what a
Wow.
hot mess do I need to solve today? um, I said, "Put him on the phone." And I said, "Dad, what's wrong?" And he said, "They don't believe me. I'm in pain. And it all started with that Nickelodeon MFer down in the ER." And he didn't say MFer. I'm cleaning that up. And I said, okay, just calm down. I'm going to fix it. He said, "Oh, thank God you called. You always fix everything." And yes, I did. And my sister. And so I said, give the phone back to the nurse. And I said, "He needs pain meds and a Diet Coke." And I called back a little bit later, and she was like, "He's a totally different guy. He's hilarious." And I'm like, "He is. And he wants to get to know you and chat." I said, "And he might try and ask you out for a date, just so you know." But I
Warning.
dug through the chart, and I found that a resident had seen him in the emergency room. And each time he came in, my dad reported the pain was in a different place. And this gentleman kept questioning him. I say gentleman, I'm not sure it was a gentleman. Nonetheless, he was challenging him. "Well, you said the pain was here, so are you telling the truth?" and all of that. And I said, "But Dad, why'd you call him a Nickelodeon MFer?" And he said, "Well, he was so young, he probably still watches Nickelodeon." And I thought, that's pretty brilliant to put that together. So, long story, treat the pain, don't judge it. Because people with dementia are not stupid. They know when they're
Yeah.
being judged. They're not brain dead until they are dead. And so we have to treat them the same way that we would want to be treated, especially in areas of pain.
Well, thank you for sharing all of this with us. I think it's really important that we're talking about it, because as we've mentioned, where people are being judged for their pain,
Mm-hmm.
people aren't even aware that people with dementia are having this type of pain, myself included, until today or recently, just because not being educated or not knowing about this stuff. So thank you for sharing all of this with us.
Yes. Thank you for having me.
Of course. Thank you all for watching. If you're interested in learning more, our website is linked in the description. Thanks for watching, and we will see you next time.